Good evening, everybody. So we heard a wonderful lecture, 25 years of experience, spoken 15 minutes. So it's not easy to take care of these kids. These children grow old, and as they keep growing, the disease is going to increase as well. So I don't think we have an ideal glaucoma surgery which is going to work for the rest of the child's life. We know that as time goes by, they scar, and especially for children, the scarring is going to be much more compared to an adult. So we have to face this problem of having the surgical failure in these children at some point in time or the other. We know to start with, pediatric glaucoma is a surgical disease, whether it is combined trabeculotomy with trabeculectomy or a goniotomy in the presence of a clear cornea. But at least 10 to 20% of these surgical cases fail over a period of time, and usually beyond a year. And secondary glaucomas like aniridia, Sturge-Weber syndrome, and so many other conditions that are there, especially the aphakic and pseudophakic glaucoma following a congenital cataract surgery, are extremely difficult to treat. And they have a higher chance of failure as well. So in the presence of a refractory glaucoma, that means your primary interventions have not worked. In the presence of a refractory glaucoma, sometimes, especially if the children are a little older, we can try with medical treatment. We can do a repeat trabeculectomy. Sometimes we also do a needling of these blebs. Sometimes a repeat trabeculectomy with mitomycin. And if nothing works, then we move on to drainage devices. The reason why I am going through this list is because drainage devices, as much as possible, are not considered as primary surgeries in either in adult or in childhood glaucomas, except in certain conditions. I'll talk about it as we go by. And then if nothing else helps, cyclodestructive procedures are something that we can benefit from. So like I said, in trabeculectomy, you know that in children, they have very thick tenons, they have very rapid wound healing response, the scarring and fibrosis is so high, so they end up having problems. And sometimes when you use a trabeculectomy with mitomycin C, we have to be extremely careful about the concentration of the drug as well as the duration that we use, because these children can tend to have these thin cystic blebs, and if they have to live with these thin cystic blebs for the rest of their life, the kind of activities that the children have, I think their chances of infection are very, very high, so we need to be very careful. Cyclodestructive procedure is kind of reserved for very difficult glaucomas because it is very difficult to titrate and predict. Sometimes we do not know. Same child, suppose you have given a suboptimal doses, for example 17 or 18 shots of a transscleral cyclophotocoagulation, it may either go into hypotony, or even if you have given 25 shots, the pressure still may be very high. So it's very unpredictable. So we reserve this for those situations where another procedure is not possible. And we also have this procedure, endocyclophotocoagulation, which we do it in some children, especially with children where the limbus is not very well defined, like in cases like sclerocornea and cases where they have very, very dense corneal scars. So glaucoma drainage implants have been there for a very long time. In fact, it's interesting to note that the first implant that was done ever was in a child when nothing else helped. So that's how it started. You're desperate to have a procedure where you want something to happen so that the pressures are controlled and you'll be able to save the vision for this child. So there are multiple implants that are available. The ones that is available to us is the Ahmed glaucoma valve implant, as well as Bavelt is not available with us, but a prototype similar to that is the Aurolab aqueous drainage device, or the ADI. And these are two things that we use. In Ahmed glaucoma valve, we have two different types of implant. One is a pediatric and an adult. So we need to be very careful when you're choosing an implant, apart from the valve type and the non-valve type, also the size of the implant. So for me, the cutoff is if the child is 8 years or less, or if the child has a very small eyeball, I prefer to use a pediatric implant. Otherwise, I go in for an adult implant. So you have to choose the type of implant. Age is not just the criteria, alone the criteria, but other factors like conjunctival scarring, previous buckles, so many other things also will play an important role. But essentially, at least age group, you need to understand that you can't go and use a huge adult implant in a baby, because one is the space is not available, plus you will also end up having a lot of problems, and the length of the implant anteroposterior is about 17 millimeters. Safe zone for you to go and suture it is about 8 millimeters from the limbus. So you can understand that the eyeball is so small and the orbit is so small, the posterior edge may even go and hit the optic nerve. So we need to be very careful when you're choosing the size of the implant. Non-valved implants are something that are very, very useful. I'll come to it as we go by. So essentially, the glaucoma drainage devices basically create a drainage or a bypass from the anterior chamber into the posterior subconjunctival space. So the anterior bleb related problems are not associated with it, but there are other problems that are there which are tube related and implant related. So the primary indications for us is whenever your primary surgery fails, or in certain conditions like Sturge-Weber's, pseudophakic, aphakic glaucomas, where you have very extremely difficult eyes to manage because of a very bad anterior segment or because of a very difficult glaucoma. Sometimes we choose to do the implants, rarely though as a primary procedure. There are certain problems in children. We know that they have very small eyes. Sometimes ophthalmic eyes are huge and they have very thin sclera, a large eye for the orbit size, and these eyeballs grow. So it's not that once you fix an implant and the tube of the implant is placed in the anterior chamber, that's going to remain stable. As the child's eyeball grows in size, the tubes become shorter. So we need to remember that the tube has to be placed a little longer. But these children also have a problem that they go on rubbing the eyes. So if you have a tube which is long, it actually leads to more complications. So you have to have a via media where you need to leave a long tube, at the same time the tube should not hurt the eye. So we have to use certain techniques when we are doing to place the tube appropriately. And also they have a very active immunological response. So the scleral patch graft that you use, the corneal patch graft that you use to cover the tube, sometimes can get eroded as time goes by. So it's not that once you have covered for the lifetime it's going to be covered. So we need, the reason why I'm mentioning all these things is we need to be extremely meticulous when we are following up these children. Every time examine it the way you examine a bleb. Every time examine the area of the tube as well as the implant. And hypotony is another major problem that we face. So there are two basic types of implants, like I was saying, valved and non-valved. Valved is something where you have a control. So as soon as you put the tube inside the anterior chamber, the valve opens up and lets the fluid out. So it's usually from a high pressure area to a low pressure area. Beyond a certain intraocular pressure, the valve is supposed to shut down and it will not allow further fluid to go out. So essentially, it is kind of a controlled pressure reduction where the pressure doesn't go too low. But also in these situations, sometimes you may end up having hypotony despite it being a valved implant because of the improper technique that you use to do the surgery of using a very large bore needle to make a needle track. So when you place the tube, around the tube the fluid will start leaking. So all these problems have to be taken care of. A non-valved implant is slightly different compared to a valved implant in that it will start filtering much later. So we ligate it with a 6-0 vicryl suture that opens up usually between 40th to 45th day. So the fluid starts going out of the eye only beyond that time. So during that period they have to be treated with the topical and oral anti-glaucoma medications, and once it opens up, the fluid will start filtering very well. So here in the non-valved implants we have bigger problem of hypotony because sometimes when the ligature opens up, suddenly the pressures may lower. So usually we count. In fact, when I give an appointment for a patient, especially a kid, when they come back, I give an appointment in such a way that I'll see them immediately after the tube ligature is opened up, because definitely you don't know what is going on, and the mothers are extremely brilliant. If you tell them, they are the first ones to actually pick up if there was a problem. The mother actually comes and says, 2 days ago the ligature opened up for my child. How do they do that? Because we try and teach them. You say whenever you put the drop in the morning, you try and feel the child's eye. If it is too soft, don't put the drop. So stop the anti-glaucoma medications and bring the child immediately. So sometimes education is very important, otherwise we end up having major problems. High pressure phase is something that we see with valved glaucoma devices, and these have to be managed, especially in children. This is a major problem. So sometimes if this is too high, for example, if I've operated a child and has had a very high hypertensive phase in one eye and it was a very difficult post-operative course for me to control the pressures, then the other eye I would choose to do a non-valved implant. So something like that where we will try and titrate what is happening, because other eye of the child, usually other eye of the same patient will behave the same way. So it's a kind of a guide for us to know. And this is a child who had congenital glaucoma, had a keratoplasty and had uncontrolled glaucoma. After that, the previous surgery had failed, has a tube in the eye. This is a child who's had one eye tube implant. You can see the HAPS cornea has cleared. Other eye was awaiting the implant surgery. So a couple of things I wanted to highlight in this is that, so here if you see, there's a very short tube. So you either have to place a tube which is not too long. Again, you have the risk of having the tube become short as the baby goes bigger, or when you place a tube, you try and place it parallel to the limbus. This is what I was discussing in the previous session as well. So if you place it parallel to the limbus, although the tube is little long, but it will not go to the center of the cornea. So even in case there is a tube corneal touch, it's usually in the periphery. It doesn't affect the vision of the child. So we need to be, even those small things, we need to be extremely meticulous. In post-keratoplasty eyes these days, in case it is possible, especially if it is a pseudophakic eye, we prefer to do a pars plana tube, because extremely difficult to take care of the graft in these eyes with tubes, because even a small touch, although the child doesn't, even if the mother says the child is not rubbing the eye, you need to understand, if they squeeze their eyes tightly, the lid eye is going to push on the cornea, that will bring it closer to the tube. So it's not necessarily a rub, but even dynamically, whenever the eye moves and the lids close tightly, you can end up having problems. So I'm showing the slide because we need to understand the kind of problems that we can end up with these eyes. Sometimes they can be dangerous. At the maximum, if your trap doesn't work, it will fail. Rarely you will end up having a bleb related problem, because the children generally don't have thin cystic blebs. But if you have an implant, if you have a tube erosion or an implant which is exposed, you can actually lose the eye. So we need to be very careful. Tube obstruction is a common problem that we see, but we need to understand that if it is because of an inflammatory membrane, just stepping up the anti-inflammatories will help, usually resolve the problem. In a post-vitreoretinal surgery eye, you can have a tube block because of oil. Early in the post-operative period, because of the tube insertion, you can have sometimes a bleed and a blood clot around the tube. Sometimes, rarely though, you also can have vitreous, especially in aphakic children, vitreous coming and blocking the tube. So if you are doing a surgery in an aphakic child, make sure you clear the entire anterior chamber, and if possible, the anterior vitreous has to be cleared, so that you don't have this problem of the vitreous coming and blocking the tube. If it blocks, then it has to be vitrectomized. Sometimes, like this is what I said, tube corneal touch. So we can trim the tube, especially with the help of micro instruments. It's quite easy to do that, but you generally don't want to take the child for any second intervention. So tube erosion and implant extrusion are major complications that we have to be very careful about, because the longer the child is going to live with this implant in the eye, there's a very high chance that the conjunctiva over the tube is going to become thinner and thinner and thinner, and the part of the tube can be exteriorized. So there's no conjunctival covering, and the patch graft that was placed was also kind of eroded. So we need to be very careful. If you have something like this, it's an emergency. It has to be operated, no medical management, and I don't think anything like that will help. And if you have an extruded plate of the implant, it has to be removed, because first and foremost, I think we need to save the eye. Then we can think of what we can do for the control of intraocular pressure. Like I said, as the eyeball becomes increasingly bigger, the tubes can retract, but don't have to worry that we'll lose the implant, because if it has been working well until now, we have something called as a tube extender. We can open up the portion of the conjunctiva, take out the tube, exteriorize it, and connect it to the tube extender and insert the longer tube inside the anterior chamber. So you can still save your implant, but we can do something called as a tube extender to be able to save these eyes. Hypotony is a major problem, especially with non-valved implants. And how do you examine these children? Checking pressure is not easy. Every time they come, they will not even open their eyes. The more you force them, the more tightly they'll squeeze their eyes, which is actually dangerous. So one of the things that is very, very useful in helping managing these children is the ultrasound B scan. Ultrasound B scan can help you, especially with an implant, whether the implant has opened up or not, because this is the picture where you see, this is the contour of the globe. This is the posterior conjunctival space where you can see the fluid around the implant. The central line is the implant, and there is fluid on either side. So that means you know the ligature has opened up, and the implant is functioning and the fluid is collecting very well. This was a child who had a choroidal detachment following the opening up of the ligature. So you don't have to panic if you see a choroidal detachment. You know that it happens because of hypotony. Children, fortunately, actually recover very well from hypotony, unlike the adults. If we don't have any leaking wound, if we don't have anything that problematic, otherwise usually they manage very well. But we have to be careful, especially in ophthalmic eyes, which are very large. They can end up having major complications. So if you look at valved and non-valved implants, depending on different types of studies that have been published, the success rates in both types of implants is almost similar, close to 80% at the end of 1 year. We looked at our own 5-year data to look at how things were working in our hands. We also know that the pressure control was quite good, but they all require at least 1 or 2 medications in the post-operative period to keep the pressures under a very, very good control. So it's not that you do an implant and the pressures will be perfect in their 10 and 12 and everything will be okay. Yes, it happens maybe in 30-40% of the patients, but the rest patients, usually about 50 to 60% of them require 1 or 2 medications, topical medications to control the pressures. The indications when we saw, most of them were primary congenital glaucomas where the multiple previous surgeries failed. And the second major indication is glaucoma in aphakia and pseudophakia. We know that congenital cataract, when you operate, when you follow them up for the rest of their life, sometime or the other they will develop glaucoma. So in fact, there was a very interesting article that was published which said when the congenital glaucoma patients were followed up, congenital cataract patients operated who were followed up for 33 years, every single one of them developed glaucoma. So it's which type of glaucoma, when they develop, what is the severity is something that is very different, but we need to follow them up because they are some of the most difficult glaucomas. Unlike congenital glaucoma, they don't have enlargement of the eyeball, they don't have HAP striae, they don't have tearing, they just get accommodated to it and then slowly they start losing the eye. By the time they come to you, it will be quite late. And they are very difficult glaucomas to manage also. So glaucomas related to aphakia, pseudophakia, aniridia, some post-vitreoretinal surgery glaucomas are extremely difficult, and sometimes we may end up doing primary implants in them. The success rates were close to 88% at 1 year and lasted up till the 6-year, 7-year follow-up, and by around 6-7 years it started going down. So when we divided them into primary congenital and secondary glaucomas, the primary congenital glaucomas were doing very well, but the longer you follow up, you realize that the success rate also starts going down. So that's why I said this will not be used unless I'm pushed to it. I'll not use it as a primary procedure, because if a first implant fails, what next? Another implant. So you have to be very, very careful when we are choosing to do an implant for a child. We have to make sure that we have really, taken care of everything else. Only then we will go in for this. Serious complication, I've had one child who developed an endophthalmitis following an erosion, had conjunctivitis bilaterally and developed an endophthalmitis following a conjunctival erosion. So that was, we could save the eye of the child, but it is very devastating when you have a problem. The other complications are very minor and usually they subside, but these tube-related problems like tube corneal touch and things like that, they have to be operated, but generally they are okay. You will be able to save the eye, that's not a problem. So like I said, to summarize, 1/5 of the primary congenital glaucoma surgeries fail. Secondary glaucomas have poorer success compared to the primary ones. Implants are a definite role in helping these children. I can definitely say that at least half of these children that we have operated for implants, if we could not do an implant, we would have lost those eyes. So if it means that even a few children are benefiting with this, I think it has a very great role to play. And choice of an implant, like I said, it has to be individualized, not just for the patient, but also for the doctor. Whatever you are comfortable with, what you think is best in your hands with least number of complications, go ahead and do that. Just because somebody else is doing something else, you need not jump because it's a child and you have to worry about the problems and complications later. Lifelong meticulous follow-up is very important because of the complications that I have. In fact, we worry about if the patient is not come back to us, we try and pull out all their telephone numbers and try to call them, because you never know, they've not come back because they've had a problem, or they are so comfortable that everything is okay, they don't come back to you. So either ways, I think we need to see them. So we definitely have to follow them up, and that is a commitment for our lifetime if we have touched these children. So we need to definitely put in all our best efforts to help these children see and for longer. Thank you.